at Duke. When were you at Chapel Hill? Oh, just for a year, so he limited his time there. He has, he had an internship at Duke. He had, he was in the Navy, served in the U.S. Navy, and was at the Naval Hospital in Beaufort, South Carolina, and also Guantanamo Bay. He spent time there with Joe's brother. Yeah. Since then, he's been at the Orthopedic, Sports Medicine Orthopedic Center, and they kind of split up, so now he's with Greensboro Orthopedics. He's board certified American Board of Orthopedic Surgery, and of course has his medical license in North Carolina. He received the annual award for excellence orthopedics research presentation at Duke in 2005. He has numerous presentations and publications ranging from the mechanical properties of human hip capsule ligaments, and from in the Journal of Orthopedic Trauma, effective intermittent pneumatic compressional fracture healing. He has other publications on specifically to ankle fractures and treatment of Weber ankle fractures, as well as in the lower extremity review, Achilles tendon rupture, return to football. I will pass this around so you can enjoy it. Thank you again for coming.
So thank you for that kind introduction. This talk came about, we started doing Cartiva here the early part of last year, 2017. It was just FDA approved in the U.S., and we did the very first ones in the triangle here, so kind of noteworthy accomplishment. But so the talk came out, what's this Cartiva thing? We would go into a new room and somebody new would see this little gummy bear looking thing and say, well, what's this all about? What's it for? And so Patty asked me to talk about it and kind of fill everyone in. So surgical advancements in restoring foot function, and specifically talking about Cartiva, is our topic for the morning. Again, I'm John Hewitt. I did a fellowship at Duke after I got out of the Navy in orthopedic foot and ankle surgery, and so treatment of big toe arthritis, or hallux rigidus, as we'll find out here in a minute, is one of the big things that I do. So, and I am board certified in orthopedic surgery. So, I have nothing to disclose relevant to this topic. I would love for Cartiva to pay me for all of the ones that I do, but so far nobody has brought that up. Every talk like this has to have objectives, and in this case, our objectives this morning are to figure out a little bit about the anatomy of the first MTP joint, recognize stages of hallux rigidus, learn the different treatment options, and then specifically to identify indications for joint resurfacing and to gain familiarity with perioperative care for these patients. And so, anatomy of the big toe joint. So the hallux is Latin for big toe, and the MTP joint, or metatarsophalangeal joint, is the one that we're concerned about. And so the big toe MTP joint is the hallux MT joint. And it gets arthritic fairly predictably. It's just one of these wear and tear kind of joints, activity and so forth. But the anatomy, it's basically a hinge, but it's got two sesamoid bones underneath it. It's going to be easier for you to see. There we go. So the sesamoid bones, this is looking up from the bottom of the foot, just like I'm holding this foot up. And so you've got the proximal phalanx here, and the first metatarsal. The two sesamoid bones are on the bottom there, and they help provide flexion strength. You've got muscles that pull the toe out and pull the toe in, and then also up and down. So what is hallux rigidus? Well, hallux Latin for big toe, rigidus Latin for stiff, so stiff big toe. That's not a very imaginative term. It sounds pretty fancy, but it's really just stiff big toe, which is the clinical manifestation of big toe arthritis. And so, So arthritis is degeneration of cartilage. Cartilage is the smooth, shiny parts of the ends of the bones that allow them to articulate with each other and move. Whenever it starts to wear out, it gets soft initially, and then it gets sort of pockmarked or a little pebblestone looking, or cobblestone rather. Ultimately, though, cartilage can delaminate, can flake off and go away completely. Bone spurs then tend to form around the joint, and this illustration here shows lots of degenerative change and bone spurs starting up around the hallux MT joint. So when you get all those bone spurs, typically you start to lose range of motion. The bone spurs bump against each other and the toe will only move so far. We see the same thing in the knee and the hip. The most common cause for hallux rigidus is trauma. Typically it starts in patients in their 50s, though I have seen it in patients even in their 20s. I've had a dancer at School of the Arts who was already developing big toe arthritis, probably from ballet, just doing various motions with her toe that caused it to wear out early. It's more common in women than in men, though there's never been any proven association with shoe wear. So everyone says, oh, high heels are to blame, that's the thing that causes hallux rigidus, and it's not the case. It doesn't seem to matter. For whatever reason, women are just more susceptible than men. So this is a very busy slide. This is the classification system for hallux rigidus. Basically, grades 0 through 4 is what you need to know. There are motion criteria, that's on the left column. The middle column is x-ray criteria, and then the right column is pain criteria. And so I don't use a goniometer and measure big-toed range of motion in the office. From a practical standpoint, what we look at are what do the x-rays look like and what is the patient's pain. And so pain, grade 0, which most classification systems don't really have a grade 0, but this one does. Grade 0 is where they don't have any pain, but they're starting to get some stiffness. Grade 1, they're getting more pain, more stiffness, more x-ray findings, and then on up through grade 4, which is very decreased range of motion, pain all the time, including in the mid-range of motion, and lots of joint space loss on x-ray. So what do you do to treat hallux rigidus? Well, you can wear a rocker bottom shoe. This is an example. It's a pretty obvious rocker bottom. This is a work shoe that's made with a rocker bottom. So if the bottom of the shoe moves and it keeps you from having to bend here as you walk, then that stiffens up the shoe and you just kind of roll along with your rocker bottom shoe, and that can be very beneficial and very effective treatment. I have a family friend who came to me for this problem, and we talked about insoles and surgery and all these different things, and I got him some rocker bottom shoes, and he's happy as a clam. Now he's also in his 70s, and all he does is mow his grass and play golf, so he doesn't have a lot of demand, and he's perfectly content to avoid a big operation and just wear rocker bottom shoes. So, but many of us would be unwilling to wear a shoe that looked like that all the time. So another option is custom orthotics. So you can get a custom orthotic and laminate a piece of carbon fiber. We used to use steel, but now you can get away with carbon fiber, which is much lighter. You laminate a piece of carbon fiber under the big toe, and it basically prevents the big toe from moving. So it turns your regular tennis shoe into essentially a rocker bottom shoe just by stiffening up that area. But again, custom orthotics are pretty limiting. They're thicker than your regular insoles. They won't just fit into any old pair of shoes. So I find that patients tolerate that for athletic shoes, and if they've got mild symptoms and you put them in a custom orthotic, so that they can go do their 3-mile walk in the evening, they'll be pretty content as long as they can still wear dress shoes to church and other stuff as they like to. So mild symptoms, orthotics are reasonable. It's not something that you can do every single day. NSAIDs, of course, Tylenol, Motrin, as you need it. Activity modification, basically if it hurts, don't do that. If you tell me that it hurts to walk 4 miles briskly at Battleground Park up the hills, I'm going to say don't walk 4 miles briskly at Battleground Park. If that's all your symptoms, then don't do that. So modify your activities, and that's a reasonable way to treat it. So when that doesn't work out and somebody has failed all those treatments, then we start talking about operations. Steroid shots, I don't have a slide for this, but I'll just quickly mention. Steroid shots, some patients say, well, can I get a steroid shot and it'll make it all go away? And there are definitely people in town who do that. I've not found them to be particularly helpful. It's hard on me, it's hard on the patient, it's a little bitty joint. There's a fair amount of the Singer sewing machine technique of just poking around until you find the joint, and that's not a lot of fun for the patient. And usually they get a few days of relief, and that's about it. So steroid shots is not the answer to this. And I've not found physical therapy to be helpful at all. So physical therapy is the answer for most orthopedic problems, but in this case, it doesn't seem to do much for hallux rigidus. So we often go straight from live with it, wear your shoes, wear your orthotics, live with it, jumping all the way to surgery in one jump. There's not a lot of in between. So for surgical treatment, there's a bunch of different options, and typically where we start is with one called a colectomy. So the first option is basically just go trim the bone spurs off, and And this diagram shows where the bone spur is on the top, and we cut that off. And then sometimes you do, this is called a Moberg osteotomy, and that's where you cut a little wedge of bone out, and that raises the big toe. And so if the big toe's artificially high, then it doesn't jam into the floor when you walk, and you get a little more range of motion. You don't actually get any more range of motion, you just have your toe in a position so that it doesn't hurt. So a colectomy, in theory, it's best for a grade 1 or a grade 2. I've done them for grade 3 and 4, even for patients that really essentially demanded it, and they've done okay. The downside to a colectomy, though, is that the arthritis is still there, it continues to progress, and I counsel patients that that's a 3 to 5 year operation. You're going to have this operation, but then 3 to 5 years from now, you're going to come back and we're going to be doing another operation. So then the next step, we're going to jump all the way to arthrodesis, so fusion of the joint, and that means you cut the joint out, you lock it together with plates and screws, grows together, there's no joint. If there's no joint, there can't be any arthritis. Arth and arthritis means joint, so if there's no arth, then there's no arthritis. And so you get rid of the joint, you get rid of the arthritis, you position the toe in such a fashion that it's up high enough so that when you walk it doesn't jam into the floor, but it's not so high that it rubs against the top of your shoe. And so that's actually a pretty functional position, and patients do shockingly well with that. You think, oh my gosh, I don't have any big toe motion, that's the end of the world, I'm not going to be able to do A, B, C, or D. Well, it's just not the case. I mean, patients jog. I had an anesthesia professor at Duke who had both of his big toes fused and still ran marathons. You can't do some things like lunges, you can't do, kneeling and squatting can be challenging. But a fusion's a great operation. It's a very reliable operation. Patients do well. They're happy. The only downside, besides lunging and sprinting and things like that, you can't wear any kind of a significant heel. And so you're really limited to maybe inch or inch and a half heel. So cowboy boots, yes. 4-inch stilettos, no. And so that's one of the big things is you lose that motion. It doesn't tend to cause problems with other joints, and so it's a good operation. Very high satisfaction rate, low risk of complications, but you do give up that motion. And so on here, it says standard of care for severe hallux ridges, grade 3 or grade 4, like we talked about. And I'd say that's, for the most part, that's accurate. I think some patients, even with grade 2, if they're really miserable, they could benefit from a fusion. So then arthroplasty is the next surgical option, and that started off historically with what's called a Keller resection arthroplasty, and that's meant essentially a matter of cut the ends of the joints out and let the big toe fly. There's no joint in there anymore, it just scars in, and it's really, I put it on here for a historic note only because it really doesn't, I mean, I've seen one since I've been here, so I've been in town 8 years now, and I've seen one, and it was unfortunately done on a young woman. She was very unhappy with it. Her toe was kind of cocked up and sort of, it just was floppy. It didn't do anything, and she came to me to see what the options were, and fixing a Keller is a real chore. I mean, it's a matter of going in, you got to get a big chunk of bone from the hip, put it in there, span it with a plate. It takes months and months and months to get over. It's a big deal, and I couldn't sell her on that. So as far as I know, she's still out with her cocked up big toe. So then from a Keller, we move to what's called an interpositional arthroplasty, and that's a matter of cutting the articular surfaces, the joint surfaces off the bone, and then replacing them with something else. And so typically we started off with the extensor hallucis brevis tendon. You kind of fan it out, sew it over the end, and just put some scar tissue basically in there. You can get away with right medical graft jacket or some kind of a porcine substitute, just wrap it over the end of the bone. And it basically just forms a glob of scar tissue in there, but the rest of, you've maintained the bone structure and the tendons and ligaments and muscles, so the joint tends to stay pretty stable. Pretty variable results on that. I mean, some people, you'll see some patients that, hallelujah, it's all fixed, everything's great, and then some patients that are just say they can't tell any difference, it still hurts. So it's not, that's not something, I did it in fellowship, I've not done it on my own since I've been here. So then from there you look at implant arthroplasties. So just like we've replaced hips and knees with metal and plastic for a long time, the idea came about to do that with big toe joints. On the x-ray there you see a bipolar implant, so 2 pieces of metal there, and in theory the pro is that you would preserve your motion. The con is that this has a very high rate of failure. Those implants don't have good fixation. They come loose very predictably. The podiatrists do a lot of these, and the best ones behave like a fusion. So the patients who've had this done and are happy with it, it's basically fused. It doesn't move, and so they're pretty happy. If they move a lot, then they get loose, and that thing goes to pot, and then you take it out, and there's a giant hole there. And so fixing that is now, again, a matter of going to the hip, getting a giant chunk of bone from an iliac crest bone graft, big operation, months to recover. So in the orthopedic world, that is essentially not done. It's been widely shown in orthopedic literature to be a bad operation, and so orthopedists generally don't do it, but podiatrists still put those in pretty regularly. So hopefully nobody in here has one that I'm bad-mouthing, but so then from there came about Cartiva, which has been done in Europe now for about 10 years. It's been tested in the United States and Canada for about 5 years, and most recently the big papers that came out were at the end of 2016, and then it was finally approved, FDA approved in the early part of 2017, and we started doing them shortly thereafter. So it's, what is Cartiva? So Cartiva is polyvinyl alcohol hydrogel. So basically it's polyvinyl alcohol in water. It's has the consistency of a gummy bear that you've left in the car for a little while and gotten nice and warm. It's about the shape of a .45 caliber round, and if you don't know anything about bullets, that would be like a big fat pencil eraser. And so it's comes in sizes 8 and 10 millimeters, so you can use it on relatively small joints. The second metatarsal in particular, but the 10 millimeter is the only one that we've used in the big toe joint because it resurfaces a good portion of the joint. So it's compliant, it's slippery, it's durable. Most importantly, it's biocompatible. So the human body and this little hydrogel implant get along very nicely, and it just sort of sits there. It imbibes fluid from the joint, and so it stays nice and plump. Resilient, but it's also very durable, and I'll show you some data on that later. The joint resurfacing process, so here's a case example, a case that we did right here up in room 5. So this is a 53-year-old woman who has forefoot pain, decreased range of motion. You can see here she's got the joint space narrowing, she's got a little bit of subluxation of the joints, she's got some little bone spurs off the side, and more importantly, a big bone spur on the top there. And so she really falls into the classification of probably really realistically grade 3 based on her pain. She hurts both in dorsiflexion and plantar flexion. She does not hurt at the central range of motion. And so we talked about all the different options, and even though she was one of the very first, I think she was the second one that I did, we talked about the risks and benefits and the fact that this was new technology, and the options were fusion or colectomy or this Cartiva implant. And she was willing to go on this experimental journey with me, and we decided to go try Cartiva for her. So this is the incision that we use. It's basically the exact same incision that we use for a fusion. So in the future, if we ever have to revise somebody and go back to a fusion, then we can do that with the same incision, which is nice. After we open it up, we look, and so those x-rays, you look at it and go, well, those x-rays look, they don't look terrible. They've got some bone spurs, some joint space narrowing, they don't look too impressive. And then you get in there, and the entire center, probably 80%, maybe 75% of her joint is just bare bone. All of that shiny yellow area is bare bone. There's a little whisker of cartilage here, and a little whisker of cartilage here, and a little whisker of cartilage here. But all the central area is bare bone. It's pretty surprising that she doesn't hurt with central range of motion, in my opinion. Down under my knife blade here, you can see this big ridge of bone spur that was sticking off the top. So over here, we've debrided all the bone spurs, cleaned up the cartilage edges, cleaned up the bone spurs on the top, and we're looking right down the barrel, right at the center of the head. So then you take a guide pin, drill it right in the middle. We now bias the guide pin ever so slightly dorsally, so you want to find exactly the midpoint and then put it just above that. Take this big reamer and drill a big hole. that's what it looks like afterwards. So you've got a big hole down in the middle of the metatarsal head. And then this little device here is a plunger, and it just pushes the implant in forcefully, and the implant just sort of sticks there. And it's very tight, and they're very hard to get out if you get it crooked or sideways or something. Thankfully, that doesn't happen so much anymore. But that's what it looks like when it's all said and done. So this little gel implant is sticking above the joint surface. And so I have a model here, and I'll pass that around. But in this one, the model, the little blue Cartiva is blue, so that you can see it against the clear model.
Can I add something to that? When you're loading these up, load them against the table, because if you load them, they'll shoot straight up to the ceiling. That's dead black hole.
Yeah.
And they're expensive, so when you're load them up against the table itself.
So we've only had one fly across the room,
Yeah.
and they are really slippery, though. I've come pretty close to dropping one myself. So this is the patient's motion immediately after surgery. So on the left, you see the kind of a neutral range of motion, and then dorsiflexion of probably 45 degrees afterwards. So pretty nice to have that range of motion right off the bat. And so this is what she looked like a few months later. Better joint space, bone spurs are gone because we cut them out. And you can just make out the little rectangle where the implant sits. You can't, the implant itself, of course, is radiolucent, so you can't see it at all, but you can figure out where it is based on where that little hole is in the bone. So post-operatively, we let patients, this is one of the other big advantages when you're talking to a patient about doing this operation in the office, and you say, okay, well, here are your options. So if you pick a fusion, then you got to be off your foot for a full 2 weeks in a splint, using rolling knee scooter, walker, crutches, whatever. Then you're going to go into a walking boot for a full month after that, and then you're going to swell and so on and so forth. With this, you get to weight bear immediately. From day one, you get to put weight on it, and then you're going to start range of motion immediately. You'll start physical therapy at 2 weeks. I let patients go into whatever shoes they want to wear at 2 weeks, and off they go. And I've had patients who came in, you know, kind of strolled in regular shoes at the 6-week mark, you know, no big deal. So it's a pretty quick recovery, and that's for people who are active and trying to maintain an active lifestyle, it's a nice benefit. And so Judith Baumhauer is the person who sort of pioneered this research in the United States. She was the lead author for this big group, some Canadian and U.S. Foot and ankle surgeons who brought the device from Europe to here and did a big controlled trial of it. And so the first study that was published back in 2016, prospective randomized controlled trial, over 200 patients, 150 of them got the implant, 50 of them had a fusion. And basically it's what's called a non-inferiority study, which is what you have to do to prove to the Food and Drug Administration that the new proposed treatment that you have in mind is no worse than. You don't have to prove that it's better, you just have to prove that it's no worse than what is currently the standard. And so that's the non-inferiority design. And so this was a 2-year study. They looked at pain, function, and safety, and they found that pain decreased significantly in both groups, both fusion and resurfacing groups at 1 and 2 years. Range of motion improved about 6 degrees. So you think, well, 6 degrees is really not very much. A joint that moves almost 90 degrees in dorsiflexion and about 45 degrees in plantar flexion, 6-degree improvement is not particularly impressive. It kind of depends on where somebody starts. So that's another thing that's important when you're talking to patients about this operation is they're not necessarily going to get normal motion like they had when they were 20, and both big toes are exactly the same. You know, they'll get a little better than where they are, but they're not going to get back to a perfect normal foot. But on the other hand, they're not going to lose motion. They're not going to be totally stiff there like a fusion would be. 9% of that group ended up converted back to a fusion, and they showed at 2 years no implant failures. Now, in other words, none of them broke, none of them came loose, none of them popped out, but no wear. So even hips and knees wear. These implants show no wear at 2 years, and no bone loss. So sometimes if an implant moves around a little bit, it'll cause bone to resorb. That was not shown in the original study. And then in 2016, Daniels, who's a Canadian author who's in the same study group, did an update at 5 years of that same group of patients. They had 27 patients who were out to 5 years. They showed still no wear and no implant failure, which that's pretty impressive. One of those patients who had been converted to a fusion, and all of them maintained that range of motion. So they got some range of motion back, and they maintained the range of motion in the long run, or in the midterm, I should say, 5 years. Long run would be more like 10 years or so. So that's, a lot of other joints have a tendency to stiffen up over time. Total ankles, for instance, start off with good range of motion, and then 10, 15 years later, they're a little stiffer than they were. They don't lose all of their motion. They don't become completely stiff, but they do stiffen up over time, and that doesn't seem to happen with the big toe joint. So what else could you use it for? So other alternative uses. So in Europe, this device is being used for osteochondral defects of the talus. That's a very challenging problem that we have, where you get a little scuff in the cartilage and then it forms a cyst down inside the ankle joint. We have very few good options, but there are authors in Europe who are actually using Cartiva implant, just drilling the hole and popping that little thing down in there. Same thing with Freiberg's infraction, which is a second MTP joint. That would be sort of the size, 8 millimeter size. If you had a big patient here in Europe, there's a 6 millimeter size available as well, and so they're using the 6 to do a second MTP joint resurfacing. And then in the wrist, totally escaping me what that's called now. Some kind of arthritis in the wrist that I know Dr. Workman has talked about trying to use it for that. TFCC tears and whatever the wrist arthritis is. You can tell it's been a while since I've operated on hands, but the knee would be another place that you get osteochondral lesions, and you get injuries to the cartilage, and any place that you had a local focal injury to the cartilage, you could conceivably cut that out, drill a hole, and pop one of these devices in to make new cartilage.
The knee, would that be something bigger?
It depends on how big the size is of the defect, but right now the biggest is a 10. So and it doesn't seem likely that they're going to make great big ones, because the physical properties, as I understand it, the physical properties change as it gets bigger. And so, if you had a 20 millimeter one, you'd have to have it 20 millimeters thick, so you got to really dig a big hole, like a deep hole. So it's unlikely that they're going to get much bigger than 10 millimeters. So in conclusion, hydrogel joint resurfacing, I think, is a promising alternative to fusion. Decreases pain, maintains range of motion, or conceivably increases it very slightly. We've done now, I think, about 40 of them here, and I think there's one on for tomorrow again. So overall, I've got a couple of patients. I've got one patient in particular I can think of who is a year out now, and she's still struggling a little bit, still has some pain. She says she feels better than she did before, but not as good as she wants to. So, but I've said, is it enough that we go back and fuse this? And so I didn't touch on that earlier. I dramatically talk about how big of a deal it is to fuse something after an implant goes bad and there's a giant hole there, and you've got to go get iliac crest bone graft and plates and all this kind of stuff. And for this, it's a 1 centimeter hole. It's a little hole, and you can actually get bone graft from the calcaneus, pack it in that hole, and do a regular old fusion operation just like we always do. And so, and the research, Baumauer has come out with another paper since then that shows that you can fuse it very reliably. So there's a good bailout. That's the reason that orthopedists have sort of seized on this as a good option, is that, yes, we're trying to resurface a joint, but if it goes south, there's still a good operation to be had. It's not going to really be a huge production to try to get a fusion afterwards. So but now, that being said, 40 into this, and I've got quite a few patients that are now out a year, and I have yet to fuse anybody. And so I'm very encouraged by that. But my counseling speech has gone a little bit. It's not a. I'm careful to counsel patients that this is not you're not going to have the toe that you had when you were 20. This is still a compromise. You're going to keep your motion, but you're going to have some pain. It's going to be a little stiff. There will be days that you think, that it really didn't accomplish much, but it takes a long time to get all the way better. And I think so far I've observed that patients continue getting better for 6 months, 9 months, a year. So, to keep wearing shoes like this?
That's good news.
So the little device is going around, oh, you got that, okay. And there's also a Fusion on here too, if you know what, if you've not seen a Fusion, there's a little Fusion model up here too. So what questions can you think of? Surgery takes less time. Yeah, sure.
I think there's one upstairs, Amy saved the one that popped.
Yeah, the one
I
that
think
went
it's
to the
still on
floor.
the desk, on the unit.
Oh, gumdrop.
So there are 2 weeks non-weight bearing?
Weight bearing is tolerated immediately.
Oh, weight bearing.
Yeah, non-weight bearing is for the patients who have fusion, keep them non-weight bearing. 2
Oh,
weeks,
that's pretty good.
start walking on it immediately. I let patients move it actively on their own, like they can wiggle their toes all they want. And then at the 2-week mark, they start cranking on it because we really don't want it to get stuck down. Surgery takes, fusion takes about 45 minutes or an hour. This takes about 20 minutes. It really isn't much. Yeah, it's not much longer than a colectomy is. This joint's very superficial, so it's not a lot of dissection. Drill the hole, pop the whole thing in there, and close it back up.
When you close them back up, is it using sutures or what?
Yeah.
Sutures.
Staples don't have a place in the foot or the ankle. Be much faster, but there's no role for staples in the foot or ankle.
Yeah.
So I close in 3 layers. I close the joint capsule over top of it, and then close the sub-Q, and then close the skin. So I really don't want this thing popping open.
Do you like them to be in what type shoe for that?
Just a flat post-op shoe.
Flat.
Yeah, they don't need their wedge. They can, this is not, it's structurally sound,
Yeah.
so they don't need protection from the front of it. They can put weight on it.
What is the cost of the Cartiva?
Question, I think it's $3,000. Our cost, $3,000. So that gets marked up 100%. So the price that goes through on the patient's bill, I think, is $6,000.
Insurance is covering them pretty well now, right?
So Blue Cross Blue Shield recently, so their tactic is when something new comes on the market, they term it experimental. Even though all the experiments have been done, the experiments have been published, peer-reviewed journals, so it is patently false that there's anything experimental about it. The experiments are finished, it's not experimental, it's been proven. And the FDA has approved it as a device. Blue Cross Blue Shield says it's experimental and just arbitrarily says they did this with total ankles, now 10 years ago. They determined total ankles were experimental, even though the experiments have been done and published and were all through the literature. And so you just had to go through this extra hurdle to get them approved. And I've only run into it once, and it did get approved, but it's the company created a website, not a website, well, they do have a website, but the company has a card now that I give to patients if they have Blue Cross Blue Shield. And they call that, and there's like a patient advocate who sort of takes on the case and goes through, thank you, puts it all together and submits it. And I've not seen one not get approved ultimately. But it's, insurance companies, the worst thing in the world for an insurance company is something that works, but it's expensive. And so, because they don't want that. I've not had any other insurance companies give me any grief about it though, and I've done them in Medicare patients, United Healthcare, work comp. It seems, so far, it's been pretty reasonable yet that I've not had anybody left holding the bag.
So they pretty well approve it, you don't have to do other conservative measures with the patient before you go to that, or will they let you just go to the, you know what I mean?
Yeah.
How some of the insurances.
Yeah, and so for instance, total knees and total hips, you have to jump through a lot of hurdles, you gotta check a lot of boxes and show all this documentation in the chart. Most patients, since the options are so limited, basically live with it or get it fixed, there's really not, typically by the time somebody comes to see me, I've already done that. I've quit walking. I've had to quit walking. I haven't worn heels in years, or, and I wear, running running shoes and tried the orthotics, or, you know, they've been through a lot of that. And so, yeah, typically I document all of that and, you know, just say they failed non-operative treatment, it's medically necessary to consider surgical treatment. And, you know, we talked about the risks and benefits of colectomy versus resurfacing versus fusion, and the patient would like to proceed with colectomy and understands that they have risks of maintaining some pain with the benefit of maintaining some motion. And that, so far, that seems to be working, other than this arbitrary Blue Cross Blue Shield experimental status. So this is the plunger that pushes the little device in, and it's contoured to actually fit the head of the metatarsal, so you bend the big toe out of the way, and then you can actually use this to find your spot, run the guide pin in through this end, and then pull this off, and the guide pin's sitting there, and then you just run the reamer over top of that. You can freehand putting the guide pin in, but it's nice to have it kind of centered. It gets the angle right for where you're putting it. And then on the back table, as Debbie says, you put the device in there with the flat side down, the hump side is up, and then you push it with this little thing. The little thing will only go in one way, so you can't load it backwards, thankfully. And then you push that down flush against the bone, and push with the palm of your hand, and it squirts this thing out, shoves it right into the little hole. If you get it off, though, it will not go, because the little gummy bear is bigger than this is, and so when it gets out of the end of this thing, it's growing, and so it has to go straight into the bone. Otherwise, it will not go. You cannot just shove the thing in with your fingers. If you get it off, you gotta pull it out, which then it wants to fly across the room. It's not ideal. There's the reamer. It's super sharp. It's got this little step on the edge to keep you from drilling too deep. Obviously, if you went past the depth of it, you could shove the whole thing down to the bone, and you're not going to get any benefit from it. So thankfully, the engineers designed it so it's you can't do that. It's a pretty simple set. 1, 2, 3, 4 things in there, which very few orthopedic sets are that straightforward.
I will add, before we were, he trialed it, or I can say trial, we used it here, and then we have it has to be approved, so we had to get Tony, and Tony didn't know, of course, the cost of, we used some other products and other companies, which I don't know, I'm not gonna say. But we had to add up, all the cost of all those. I had to turn in a list of what we would use for a fusion and all the plates and everything to try to rationalize, the use of this in addition to all the other reasons to do this case.
Do I just pull the thumb drive out, or do I have to eject it?
That should be fine.
Okay, mess this computer.
So that feels kind of hard, and does it get kind of soft once it gets in there?
Which one's hard feeling?
I took it.
Oh, that one's doesn't have any water, so that's just the
Oh, okay.